Good afternoon, everybody. I'm Peter Hudson. I'm the Director of the Centre for Palliative Care. The centre is the academic arm of palliative care services at St Vincent's, and we're also a collaborative centre at the University of Melbourne. So I'm delighted to welcome you to this, our first Hot Topic delivered via webinar. The Hot Topic series is something we traditionally conduct face-to-face. We usually have a few forums per annum, and the intent is for us to highlight a particular contemporary issue in palliative care and provide a mechanism by which we can have an open discussion about that. And there isn't anything more topical at the moment than COVID, so I'm really pleased that we're able to offer this webinar to get some reflections and insights with regards to the implications for palliative care, but also importantly to hear about some of the perspectives of an ICU experience in a pandemic. So I think we've really got a great subject matter on offer for you this afternoon. Just before I introduce our first speaker, just a couple of things for noting, if you wouldn't mind. So each of our presenters will have about 15 minutes to present, and then following that we'll have Q&A time, which will be approximately, hopefully, sort of 15 to 20 minutes. So you should all have an option on your screens to highlight a question, and I would encourage you to do so because we have allocated, as I said, ample time for discussion. And you can post those questions as the speakers are presenting, and that way when it comes to the Q&A time, hopefully we've got a stockpile of questions already ready to go. What would be helpful too is if you're able, please, where possible, just to acknowledge in your question who it's intended for, whether it's for Antony or whether it's for Mark. If you're not sure, that's okay. In that case, then I'll ask either Mark or Antony to respond, whoever wants to, and perhaps both might in that instance. But where possible, please indicate who the question is intended for. So I'll introduce now our first speaker, and that's Associate Professor Antony Tobin. Antony is the Chief Medical Officer at St Vincent's here in Melbourne. He initially trained in respiratory medicine and subsequently as an intensive care physician. Following completion of ICU training, he worked as intensivist in a government hospital in Hong Kong for a 2-year period that coincided with the SARS outbreak. He's worked full-time at St Vincent's since 2003, and as an intensivist in the recent years, he's taken on medical administrative leadership responsibilities. So I'm delighted to welcome Antony and as our first speaker. And please, Antony, proceed.
Thanks for that introduction, Peter. I suppose some of you might think this was a long time ago, but what I'd like to speak about today is really just a very brief personal overview of my experience during the SARS epidemic at working there as an intensivist, because I think there are a lot of parallels for our current experience with COVID. And really I just want to talk a little bit about the impact that it has on staff and patients and families, and some of those things that perhaps are unintended. So this is the hospital that I worked at, Queen Mary. It's a government hospital. Looks like it's in the countryside, but that's just Hong Kong main city is just over the hill behind that. And this was associated with the University of Hong Kong. We had known about a sort of unusual outbreak of pneumonia in southern China for some weeks, but we didn't have a name at that stage, and we actually treated this as from the seminal paper in New England which talked about the outbreak in Hong Kong. We treated index patient 4 not knowing that he had SARS, and we didn't take any precautions, and we were lucky enough to get away without getting sick. And it was only subsequent to that we sort of, there was outbreaks in the mainland part of Hong Kong that we subsequently started to take precautions. In terms of the current outbreak or the pandemic, this is an epidemic, but in terms of the pandemic, the numbers are tiny compared to what we're experiencing at the moment, with a cumulative of about 1,800 cases. over the 6 months, and a peak of only about 1,000 at any one time, with about 150 odd patients at the peak in the intensive care, and a cumulative sum of about 300, 350 patients who died. So much, obviously small, but really quite a profound impact that it had. And what I'd like to talk about is really about the impact it has on the hospital, the impact that it has on patients and families, and also the impact that it has on home life and social life. So, the mask was worn from the front door of the hospital. I used to carry my mask as I walked up the hill to the hospital, and then put it on when I went in, and wore it all day. And it really becomes a very alienating thing to be wearing a mask all the time. My Cantonese is pretty ordinary. It's about 20 words. And I've got a terrible Australian accent, which you probably picked up on. And so between those two things and wearing a mask, communication was very difficult. Recognising people is not easy. Even, we had to wear name badges. In the end, we clued onto that. But it really does make interaction with your colleagues, who you know quite well, very, very difficult. We learned about not touching our face, and it's amazing how frequently we do touch our face in normal sort of day-to-day interactions. And that was a really sort of quite an interesting thing to sort of have to come to terms with, restricting, stopping yourself from touching your face. I suppose in terms of the masks, the N95 was what we should have been wearing, but very much like we've had experienced in Australia and all around the world at the moment, there wasn't enough, and there certainly wasn't enough of the small sizes for some of the women, and there was something very questionable about the allocation of masks in terms of, as a doctor, I was able to get a mask, although I had to wear it for weeks on end. We couldn't change them every shift or every few hours. But for the nurses, they often didn't get the same allocation of masks. And I think we've seen that again in the COVID experience now, that there are craft groups who feel that their well-being is more important than others. And there is very quickly, people can become very tribal in terms of protecting themselves and forgetting about their colleagues who they've worked closely with for some time. One of the major things that I reflect on a lot about my time during the epidemic of SARS was the impact, or the antagonism between staff safety and patient harm. We very early on realised that nebulizers were potential for spreading SARS, and so we banned nebulizers on the wards, but without appropriate added precautions for looking after people in terms of spaces or having enough metered dose inhalers on the wards. And I vividly remember a young lady who died, a couple of young children, because of severe asthma, which was inappropriately treated or not treated, essentially. And again, we didn't have appropriate resuscitation equipment on the wards, and we weren't able to intubate her before she got severe brain damage. So it's things like that where you see the unintended consequences of well-intentioned actions to prevent spread can have very severe unintended consequences on other patients. Similarly, for non-invasive ventilation, we banned non-invasive ventilation because of the risk of aerosols. And again, left patients with COPD and acute pulmonary edema essentially either left untreated or having a much more aggressive treatment like intubation, where it otherwise wouldn't have been necessary. Ban CPR, even when people were wearing PPE, CPR was sort of frowned upon, and we were sort of strongly encouraged not to do it. I recall, just go back one step, we set people up, when people came into hospital with a fever, they all went to a holding ward, a query SARS ward, and on this occasion there was a 40-year-old university professor who came in with acute cholecystitis, but because he had a fever, he went to the fever ward. And I was called to see him in the middle of the night, and by the time I got my PPE on, got in to see him, he was in profound septic shock and near arrest, and then he arrested in front of me, and I didn't do CPR, I didn't resuscitate him because of, I had people around me who I felt responsible for in terms of nurses and junior doctors, but that man died because of the consequences of the systems we put in place to protect staff. And, it goes on for bag and mask ventilation. Similarly, intubating people often led to harm because we changed the way we did things without really thinking through what the implications of those changes were. Patient triage was interesting. There was people who would refuse to see certain people with fevers. I remember going out to actually triage someone in an ambulance because the emergency department refused to let the patient into the emergency department because they had a fever. The patient had tuberculosis. He was coughing up blood. He needed to be admitted. But again, the fear that people had at the very beginning was to sort of basically push back and not want to see patients. And I can understand that there is this sort of antagonism or balance between protecting patients, treating patients, and staff survival. And when people are afraid, when staff are afraid, sometimes we make decisions which we otherwise, in hindsight would not. And the systems that we put in place to protect ourselves can very often lead to patient harm. So this was sort of I apologise, the backgrounds are too dark, they've been corrupted. This cannot exclude SARS was basically the mantra for a lot of admissions and many admissions where clearly there was an alternative diagnosis. And it sort of, on one level, was personal fear that people didn't want to have to interact with people if there was some possibility of SARS, versus the fear of making a decision and perhaps being wrong and being judged. And the medical system that I was working in was very, very hierarchical. It was very judgmental, and there wasn't. Perhaps people were too afraid to make a decision or to call something for what it was, and so this also led to difficulties in that, and we see it again with COVID, that people were sort of labelled as having one disease when it was clear that they had something else. You've got to remember that SARS, in terms of community spread, was very, very uncommon, and not like the situation with COVID in sort of New York or London. Staff morale. You can see that from this was towards the end of the pandemic when we were a bit more lax with our PPE. Staff were confused. The government was fairly unpopular at that moment. And I think they were slow to get their message across. They were slow to sort of support hospitals. And that led to people becoming very confused and being open to rumours. There was certainly a lack of medical leadership within the hospitals. In many respects, the senior medical staff went missing in action. They would often refuse to see people. The junior staff had to go in. The junior staff were the people who manned the COVID intensive cares. And that's not across the board, but there wasn't the medical leadership that was necessary, and that again led to the propagation of fear amongst junior staff and nurses. And people were right to be scared. They were scared about their personal safety. People were very scared about their family well-being, and some of the intensivists didn't go home for 6 months. They just stayed in the hospital for fear of infecting their families. And we've got to remember that some of these people had close friends that had died just across the harbour from SARS, and so people were justified in their fear, but it's really lacking. There was a lack of support to control that fear often, and again there was anger because of the lack of PPE, and as I alluded to, the inequitable distribution of workers to SARS areas, where again I think there was a lack of senior leadership in that. In terms of patient and family, I think there was certainly a social stigma associated with SARS, more so than perhaps with COVID, where it's much more widely spread. And I think to have a relative with SARS or to be related to someone with SARS did have a social stigma attached to it. Interaction with staff was very difficult. I mean, I chose not to wear gloves because especially not having much language, I think it's important to be able to, hold someone's hand for them to, have real contact rather than through a glove. But for patients and families, to see staff that are just masked and gloved and, really to be anonymous is very difficult. We had a policy of no visitors. Again, that's very isolating for patients. And in the intensive care where we had people who were dying, families were unable to see or to touch their dying relatives. And, they weren't there when the patients, their family members died. There was interruption to the normal funeral rites. And so people weren't able to have the usual closure that we would normally expect when people die from a critical illness. Home life was interesting. There seems to be this fear of lift buttons and handles, which seems to have been carried through into the COVID experience, where people don't want to press buttons or open doors. I think it's a bit unusual, but certainly it was very unusual in SARS. When I used to get back to the apartment, the doorman was there wearing his mask, which is fair enough, but he'd have one glove on so that he could press the button and spare me the risk of pressing a lift button. They cleaned the lobby regularly, and most public areas smelt of bleach because of that. Restaurants were fairly empty. They didn't have the same social distancing rules or closures that we have during COVID. And Hong Kong, as you can imagine, is fairly crowded, and it was very difficult to get in restaurants. So we quite enjoyed actually the ability to go to restaurants and not be sort of squeezed in or being told we couldn't get a table. So in some respects, it was a nice time to go out and socialise. The flip side of that was that people didn't really want to associate with doctors, and we had quite a few close friends that really, without saying so, were quite reluctant to come in contact with us. And I suppose that's, on one level, that's fair enough, but, as I said, there wasn't that much SARS around, even though I was dealing with it on a daily basis. And so, it was isolating in that way for us as a family. Watching the toll on TV every night, that's something that we do with COVID, and that again becomes very ritualised, just seeing what's happened on day to day. And that familiar thing with family calling us up to make sure that we're safe, and because they've been watching the news as well. So in conclusion, I suppose it's just the three take-home messages from that. It's a very brief sort of overview of just touching on a few subjects. I think that infections like SARS challenge our ability to manage an infectious threat whilst maintaining care for other patients' conditions. Strong leadership is required to manage the fear and the anxiety of staff members at risk of infection and possible death. And the impact and management of infectious diseases such as SARS and COVID-19 is as much psychosocial as it is medical. Thanks.
Thanks very much, Anthony. That was fantastic. We're very fortunate to get your insights and reflections on that experience, and I'm sure there's going to be some questions that arise from your presentation, but that was terrific. Thank you very much for your time and preparation of that. I can see that we've got, it looks like close to 70 participants online, so that's fantastic. Thanks, everybody. And just in case you've joined us late, I would encourage you to pop in your questions as we're going, so that when we come to the Q&A time in about 15 or 20 minutes, we've got some questions there ready to go. So please don't be shy. I would now like to introduce our next speaker, and that's Associate Professor Mark Boughey. Mark's the Director of Palliative Medicine at St Vincent's in Melbourne, and he's also the Deputy Director of the Centre for Palliative Care at St Vincent's. He's got a long-standing history in palliative care in a variety of roles, and he's also currently the Chair and Clinical Lead for Safer Care Victoria's Palliative Care Clinical Network. Mark's got a particular passion for education and training, as well as program and model implementation in palliative care, and a particular interest in developing initiatives with Australia's Indigenous communities. And he's been, as many of you who are at St Vincent's will know, at the forefront of the kind of palliative care response to COVID. So I'd like now to hand over to Mark for his presentation. And just a reminder, please, if you've got some questions, pop them in as we go, and then we'll come to those after his presentation. So thanks very much, Mark.
Great. Thank you, Peter, and thank you, Anthony. Antony, it's always remarkable to capture the personal experience of living through. I guess we'll all have this personal experience now of COVID-19, but to hear from your reflections in Hong Kong, Antony, rather than what you can read in journals and so forth, which are much more matter of fact. I think in many ways, those of us that work in palliative care and those in the audience who work in palliative care can understand the benefits of what palliative care is or can represent to those that practice the sort of holistic approach, rigorous sort of communication, rigorous trying to find ways to communicate goals of care and so forth. And we understand that in an epidemic and in a pandemic, that obviously for a relatively new professional group in all disciplines of medicine, nursing, allied health and so forth, that really to a health system that's already recognising it's going to be swamped, there seems to be a whole issue about how do we care for patients, how do we care for the people so that their suffering is relieved, but also how can we make sure that they don't feel isolated when in fact the very nature of their condition brings isolation in many, many ways to them. So the challenges are there, and I think it's just interesting to reflect on a Washington Post headline about 4 weeks ago that said, really, this has been a time for where palliative care has really found its footing, unfortunately, on the effects of the pandemic and the deaths that we haven't seen in Australia per se, but certainly overseas has been quite difficult to see. So in many ways, I think what we have found is that actually people did learn a lot from what had gone before us, from SARS right through to the H1N1 virus epidemics. And really, in many ways, the pivotal article arose very soon in February, early February, by Down et al. Around palliating in a pandemic. And what they did, they looked at what had happened between SARS and the H1N1 flu pandemic. And so, as you may recall, SARS was sitting around the years of 2002 to 4, whereas H1N1 was sitting around 2009. And what they really acknowledged was that, really, as we all know already, that pandemics would threaten the health system. But primarily it was a focus on resource utilisation and really presenting triage systems that, anticipated that there'd be lack of capability and capacity in care, but it was all about care escalation. It also noted that in many of the jurisdictions there was acknowledgement that that patients were going to have to be managed in a way that potentially meant that they would be denied that escalation of critical care. But in fact, what wasn't understood was as to the planning around how could we facilitate, communicate, work with people in the anticipated surge, that maybe it's around the delivery of care, irrespective of whether it was escalation to critical care and ventilators, whether it was care at the bedside, in the ward, care in the community, caring at home, and so forth. So what they found, I think, is that even though there was a lot of discussion around the engagement and involvement of people that could work in what would be seen as a palliative care framing, it really found that there was no evidence that really no one had really done a lot of planning in this space. And so it was these authors that took responsibility to write this article, and in fact this became a pivotal launch pad for our advocacy in the current COVID environment. What they did was to do some critical modelling around the principles and ethics of practice and what that really meant in a pandemic phase. and then also some of the very specific tasks that needed to be attended to. So generalists could have sort of rapid development of capability and capacity to practice in a palliative care sense, in a way where palliation and palliative care became realised. I think it really felt, though, that failure to consider this aspect of care in the surgeon, maybe this wasn't part of the experience in 2002 to 4, but really, in principle, people should be cared for, but in practice, how it would really undermine, if we didn't actually build capacity to engage palliative care, that would really undermine these sorts of processes. And in doing this, you are challenged by the issues of patients and families, and even healthcare professionals that are caring for people in hospital settings and community settings, that somehow the health system has abandoned patients, in denying a role in their decision making and really being left to die in a way that we consider not good, in terms of the pictures we would see nightly, say, of New York, where there were sort of bodies coming and building mass graves and things, in the sense that maybe people had died in isolation and a sense of suffering and so forth. So really, I think there's great questions in this particular time around 2009 when these were all raised. And in such circumstances, I think, as Antony's pointed out, it wasn't only the patients and their issues, the families and their ongoing issues, and issues that are most really still affecting them to this day as to the death of their loved ones, but also to the healthcare professionals and the stresses. And we've all seen our own healthcare professionals dealing with their own anxieties, fears, stresses, in recognising maybe their own mortality in this space for maybe the first time in their lives. And so therefore, I think a lot has been learnt, and this article really helped to bring this to our attention, to the palliative care specialists who wanted to drive and advocate for this. I think it's important to also understand why it's important to plan for palliative care, and I've alluded to a few things already, but really I think it's not only in the day when this article was written, it was really understanding the principles of practice and what palliative care brought to the table. Now, as you know, for those who work in palliative care, the evidence that rigorously supports what palliative care and its specialisation in practice brings to the table. And really what it does bring is is that sense of care at the bedside, where one understands care across a person's illness trajectory, that really you can contextualise the care for the situation, the timing, the place, the circumstances that this person's facing their illness. And it's not all about escalation to a ventilator, but it's about escalation and context of care, of whether that's vigorous symptom management, moving towards dying, or whether it's stabilisation, whether it's ongoing care, or if indeed it is triaging to the use of ventilators and so forth. But really it's around understanding where that person is, and to be able to then communicate that to the patient, to the family, and to the other healthcare professionals. It's also the principles of understanding that ethical considerations are important in care, that they need to be sort of at times looked at and focused on and unpacked, and discussed with people as to the issues at play. Also, the recognition that communication skills is indeed a therapeutic tool, and much of the stresses that people experience, the discontinuity or the incongruence of expectation of a patient, family and healthcare professionals, can be negotiated through that sense of utilising the therapeutic benefits of good communication. But also then the recognition that we're not just caring for the patient, but we're caring for the family and the care. And very pivotal to this is that sense that the patient doesn't feel isolated in this space, but also that the families can somehow feel connected, even though there's physical barriers and so forth to care that's being provided. So not only is it important that this article suggested that there were going to be issues and that we needed to build capability and capacity, but there are good reasons why the capability needs to be built, and that palliative care represents a collection of practices that can help facilitate people to feel connected and heard and valued in the system, and so forth. Getting more specifically though, not only do we focus on end of life and the good care, but we also need to appreciate that the grouping of people that practices as specialist palliative care is relatively small. So we really have an obligation as specialists to really be building capability and capacity and proactively working around this space. Determine what the specialists need to be dealing with. We need to determine what our role is, but to allow generalists to be able to take on some of these roles, be supported in those roles, and to feel safe that they are able to deliver the best care, even though they may not have that specialist on tap to come and see the person at the bedside. In this particular slide, it really shows the things that they talked about in this space, the 4 key principles of the stuff in terms of what things needed to be able to be delivered to patients in a pandemic, and that's going from particular medication to treat certain symptoms like breathlessness and so forth, terminal restlessness, delirium and so forth. What are the key medications that needed to be with the patient, not to be delivered 4 or 5 days later, or not to be found wanting when they were necessary, depending on their location of care? What was the equipment? Again, the issues to do with PPE and so forth, but the delivery mechanisms, if people can't swallow and so forth. So very practical things needed to be considered for patients in these situations. Again, I've mentioned the staff already, and the identifying the clinicians that can provide the sort of specialist care, but then to be able to build that capability and capacity within staff. So there are key people that can work in this space, ones that can start to look at the proactiveness of providing the understanding to patients around care planning, understand what their goals of care may be, start those communication and conversations and so forth, to make sure that in many ways that the decision making isn't necessarily going to be a one clinician, one physician, one person, that it's a shared decision making, and that shared decision making sits with the patient and the family, as well as the healthcare professionals, but to make sure that there are those frameworks around, that there are people that can help to facilitate communication so people don't feel isolated when indeed they're physically isolated from family and so forth. So to use technology, if able, at that stage, with our modern technology, to provide that support. Also then to identify where people can, again, that the whole notion of the sort of space where people that are not necessarily affected by COVID are still provided with the same care, but those with COVID or a pandemic have the care that we're hoping to, so that we're not, as Antony mentioned in his discussion, that we're not pushing the frontline people to be the most junior staff members, that really the consultants provide the same level, if not more level of contact and care. So taking that broader responsibility to make sure that delivery of this can happen, if it needs to be in the community, that we're ready to go, that things are prepared and ready to be delivered with the patient as they go home. Or if they're not able to come into the hospital, or if they're in the hospital, we can respond in a timely way, that we're not delayed in providing that care as is required. And the fourth one is the systems in place. And as I mentioned, it's the supporting systems, the systems that can allow the junior doctor or the nurse at the bedside to know that that conversation they're having with a patient is well supported, that they understand the principles of what they're delivering, that the medication is consistency, we're trying to minimise variation and so forth, and to create systems that then not only preempt those conversations, but to allow clinicians to debrief afterwards, to kind of help families to come back and bring people together and so forth. So I think that's a very important part. And in fact, this most probably slide was the most pivotal slide for us in palliative care to work from, and really gave our committees working in the pandemic planning the sort of areas to really focus on in the work in the last couple of months prior to things coming up to the February, March into April period. So really we also had to determine when specialists in palliative care needed to be a little bit more hands-on in the sense, and really to derive that from the fact that it really is ones that were already involved with palliative care teams and so forth. Those complex issues, which could be symptom issues, it could be complex psychosocial issues, it could be complex family issues playing out, or it could be complexities of their healthcare issues, multiple morbidities, as well as COVID playing out. There could be addiction issues, there could be opioid issues, there could be complexities of people of younger age, people who've got younger children and so forth. So there's a whole lot of things that can really come into play in this space for patients and important. And I think sometimes it's not recognised that sometimes that there are situations that are more complex, and so complex you knew in a pandemic that you do need a more specialised view, even though you've got the generalist capability and capacity being built. And I think the important thing, again, as I mentioned before, is a sense of understanding what is trying to be achieved to try and mitigate suffering, but also that isolation doesn't sit there. People aren't having things attended to when indeed they need to be attended to in a more specialised way. I think the other important part, of course, is the advocacy to make it happen. And I think for me, reflecting on this article and other articles that have come out since, that have utilised what was described in this article in reflecting on both SARS and the H1N1 pandemic or the epidemics, was that really it is around the advocacy. And I think I'm using the work that we've done, and again, I'm sure many jurisdictions have done similar work. I'm sure many hospitals, health services, and at St Vincent's we've been very fortunate to be involved in shaping some of the key pieces of work that feed into how then the palliative care can articulate. And in many ways, as you know, many people have developed their own kind of principles of ethic of care. What does that mean at bedside to the patient, to the healthcare professional? And from that to look at how do we frame our goals of care conversations when people are coming into a health system? How do we then recognise that in terms of escalation, de-escalation of a COVID pending diagnosis, how do we work with that patient? And what are the criteria, what are the things that we work with to manage that? And then obviously, how do we work the daily flow? And how do we work with that? How do we bring, as I said, the key specialists together, the consultants together, and the junior staff around that daily workflow? And I think that's a very critical encapsulation of maybe the things that, and maybe it's been a driver for us through Antony's experience of the disconnect between the various elements of the healthcare system at play in a particular health service. And I think then it was up to us in palliative care to actually show how we would connect, not to say that everyone has to be dying, but there are elements in that where palliative care can be of benefit, whether that's the complex communication around difficult congruency of care goals and whether it's making sure somebody in ICU is making sure that there is the proper communication happening with family into the community, the bereavement follow-up happens post-death, or is there a space where the loved ones can see the patient maybe when death has occurred prior to leaving the hospital and so forth. So a lot of things needed to be considered. And this looks a little bit detailed here in this particular slide. But really, if you look on the left, it really is focusing on those key documents that have been developed, the advocacy part, being part of these groups. But really, just to give you a flavour for our palliative care, we spent a lot of time conceptualising how palliative care in the 8 categories, which are the critical ones, which are moving towards the ICU setting, what our role was and the timeliness of that being sort of the traffic light colouring. The B group, which is the bulk, we're expectation of the bulk of the group, where the sort of movement needs a lot more discussion around what was going to be best care in the ward, what was going to be care that could potentially be escalated but could maybe not necessarily be. The ones that were in that fragile population group, the ones expecting the majority, maybe the older, a little bit older, more frailer, more comorbid patients. And then the things that we could do, and in many ways we saw that group as helping the generalists to start to talk about the limits of care, start to place those, give some reality, not for us to be hands-on in providing that, but really allowing the generalists to, or the other specialist areas to, in the pandemic, to understand that that's something that they could work with. We could help them to understand what those limits of care could be, what the communication tasks at play could be, what, sort of giving the context and helping to support the other clinicians. And then when we come down to the C group, which again are the ones that really are coming in or being seen and recognising through their advanced care planning, there may be the combination of their issues of frailty and morbidity and age that maybe best care of the care of focusing on good symptoms management, stabilisation at the bedside, but it inevitably may lead to dying. That then, indeed, that was when the complexities of those things most really needed more of a proactive hands-on approach, able, depending on the sort of numbers and so forth. So again, just giving a brief context there. But in advocating for this, and this is what I think truly came from the work that came in this publication, it was advocating so that we were either drivers or participators in those key pandemic task force type work. And then for us at St Vincent's, and again, I'm sure in many jurisdictions, our end-of-life and bereavement care working group, which really was our palliative care and end-of-life care and pandemic working group to advocate for these. And that was really much driven by us to really set that up. But then we had the ethics of care to devise the ethics, and that was a broad hospital group that we were participators in. The communication skills training group, very much driven as a driver coming from work that palliative care had been doing across the hospital for a number of years, really bringing that together and to then help frame that for our generalists and so forth. And then really, as we found from this in the advocacy now, is being part of those key consultant-led meetings which happen regularly, maybe across the day. At the moment it's once a day, where respiratory ICU, general medicine and palliative care come together and other subspecialties as needed to actually talk about where that patient may be best triaged in the system, as where the flow will go and so forth. So I think that's been absolutely critical in this space. And so again, this always the eye on the future. To us, in many ways, this has brought palliative care to a new perspective and level that really some of these things that have happened, I think we can learn to the future as to where palliative care then sits and how it can still contribute, focusing for many maybe on dying, but also the broader range of connectors in activities around the health service and the hospital that contribute to the general well-being of a health service and a hospital and so forth, not just specifically to those that have the needs of the dying patient. And I often think when I see this film clip that comes up on the ABC, that really it has taken many people to get to this point. And I see the meetings that we have within our health service, but the meetings that we have within Safer Care Victoria, the meetings where we interface between Palliative Care Australia and our Australian-New Zealand Society of Palliative Medicine, that really we're building on many people's experiences and works. And really that has, I think, been very empowering for palliative care in this space. If I was to look back to where I was in 2004, which was just heading to Darwin as the Territory Director of Palliative Care, I think palliative care had about 10 staff across the top end and about 5 staff across the Central Australia. And I can only imagine how ill-prepared we would have really been there to provide good end-of-life palliative care across a healthcare system. And I can only think now, in 2020, how better prepared we are across particularly countries like Australia. And even though our experiences haven't played out in the same sort of way, I think we're well prepared to take it forward from there. So I think it's been important understanding, but important learning and important ongoing care that we can provide to the services. Thank you.
Thanks very much, Mark. That was great. And thank you for people who have posted questions. I'm going to go to the first question for Emma, and it's for Antony. And Emma asks, with what you have learned from Hong Kong, Antony, what would you have done differently this time?
Well, I think it's fair to say that we've done a lot of things differently this time in terms of planning for the COVID pandemic. And I suppose specifically, I've been very aware of the potential side effects of changes that we introduce, when we stop using certain therapies, or when we direct certain therapies to be given in a specific way because of concerns about staff safety. I suppose I've been much more aware of the potential side effects and been monitoring more closely for harm to patient groups because of how we're managing potential COVID patients. I suppose also I've just been much more aware of, especially as I've got a senior role, in supporting junior staff and nursing staff, and just making sure that they have the information, and they've got a single source of information, so that they do feel supported and they do feel safe. So I suppose it's just really changed. I suppose there's both the patient protection side and also the way that I've engaged with staff that have been quite different for me this time around.
Thanks very much, Antony. Thanks very much, Emma, for that question. The next question is also for Antony from Sharon, who would be interested in knowing what funeral rites were undertaken within SARS, and in what way was it different?
Yeah, I suppose, I can't really comment on what happens outside the hospital, but it was really around those, patients being able to say prayers by the bedside as a family, sitting with the body after death, washing the body, having open coffins, those sort of things that, we commonly expect, or, we were used to people, or if you like, sort of allowing people to have those freedoms previously. But, once you've got an infectious disease like SARS or COVID, or indeed Ebola, where it was behind a lot of the spread of the disease, you have to really restrict those things, and it can have big impacts on people's ability to come to terms with death. So I suppose that's what I was trying to get across, not specific religious differences.
Okay, thank you very much, and thanks, Sharon, for that question. Next question is for Mark, and it's from Deirdre. And Deirdre would like to know, Mark, what role can specialist palliative care play in aged care within COVID-19? And she comments that we've been lucky so far in Australia, but obviously from the OS experience, many thousands of deaths have occurred in aged care, with many people being abandoned. So Deirdre would be keen to know what your insights might be with regard to the role of specialist palliative care in aged care. Thanks, Mark.
Look, thanks, Deirdre, and I absolutely appreciate that for many, the aged care sector and some of the issues we've seen unfold often raise great anxiety. I know from, again, our experiences through our network at St Vincent's, we basically worked with our community-facing aged care providers, our residential in-reach program that reaches out to in our catchment, about 40 aged care facilities, and proactively staff were redeployed to contact those facilities and go through their patient lists around things around advanced care planning, medication availability, the sort of the preemptive planning. So if indeed problems did occur, at least there'd been some consideration for each of the residents and so forth. But then again, working within the framing of things that the government, between the Commonwealth and the state, were devising, and in many ways it has been through the trial and error of predecessors to recognise that there isn't one way of doing it. And specialist palliative care, I think, in many ways has helped to guide people like the Resi InReach into the work that they can do. Specialist palliative care has been able to make sure that if indeed an aged care facility doesn't have provision of those medications or haven't got availability when they're needed, that something can be done relatively quickly to get those medications in place, use kind of ways of utilising syringe, disposable syringe drivers and all sorts of things like that. So very practical things. The other thing is, again, that sense of being able to take some kind of, at times, not only a telehealth approach to communication, but also have some frontline staff being able to manage things within the place of residence, or indeed advocate for that person in their residence to be cared for in a healthcare facility. There may actually be a lot more going on for patients than necessarily just the COVID infection, and it may actually be the reverse, that really we should be bringing, for some people into a health service to help facilitate those sorts of more critical, complex conversations.
Great. Thanks very much, Mark, and thanks for that question, Deirdre. We're going to need to finish up in a minute, but I might just go back to our presenters and just give them an opportunity for any concluding remarks or any other insights that they might have, and perhaps if they could just think about for the future as they see this pandemic playing out, any kind of insights or recommendations from their perspective. So a fairly sort of open opportunity for some concluding remarks. So maybe first to you, Antony, if you wouldn't mind. So please go ahead.
Yeah, question without notice. Look, I think that it's fair to say that this is going to change the way we do medicine for a long time. Yeah. I think many of the things are going to be for the better. I think that we're going to, like a lot of the society, we're going to leap sort of 5 or 10 years forward in terms of a lot of our practices. But we are going to be left with this lingering problem of how do we deal with sort of low-grade continuous infection. Well, not continuous, but spot fires, and how we get back to caring for patients in a way that addresses all their needs, but still keeps our staff and patients safe. And I think that's going to be the real dilemma for us. What is business as usual going to look like for us as clinicians when we have got the concern of bringing someone into the hospital who may have COVID that's going to infect staff and infect other patients, but not being too restrictive so that we therefore harm other people, as we saw during SARS, where restrictive practices prevent people from getting the care that they need. And I think that's really going to be our dilemma. That and, perhaps how do we practice safely together as well? We're so used to working in close proximity to each other. How do we safely distance in the workplace? These are, as I alluded to, these are societal questions which are going to be very difficult for us to work out over the coming sort of months and years. I'll leave it there and let Mark have a few words.
I would agree with Antony. I think really it's jolted healthcare services to an extent that I think we don't really know where we're settling. The sort of tremors that sort of happened, I think it's caused a lot of good changes to occur, but I think it really will continue to reshape. I just hope that reshaping continues, that the connection between community and hospital-based health services are more integrated, and that there is a real sense of that the patient-family journey between the services, and that really places that, again, was alluded to with aged care, that people and parts of the health system that have been really marginalised are actually recognised that really they need to be cared for in a proactive manner, and an important way that isn't seen as sort of two-tiered, that we need to make services more robust so that people can still have those choices as to where they want to be cared for, but we have the right systems in place to support them when indeed there is a issue to do with things like COVID or other sort of potential pandemic infections and so forth. But I think we have the challenges of contracting budgets, but the need to keep that momentum moving forward. So I think the advocacy and leadership across the whole healthcare sector, and maybe a cutting of a little bit of that red tape that's happened, continues on into the future.
Thanks very much, Mark. Thanks, Antony. We do need to conclude, and I really appreciate the time and effort that both of you put into today's webinar. I think we're very fortunate in Australia to have, a leader like Antony in ICU and a leader like Mark in palliative care to be helpful in guiding the response to COVID. So we're extremely fortunate, and on behalf of all our participants, thank you both for all your efforts today and for the subsequent work that you're going to lead with regard to the response to COVID as it plays out over time. And also thank you very much to the staff at the Centre for Palliative Care who organised this particular webinar. So thank you indeed. And especially to you, our participants who have taken time to be here and be involved today. So thank you very much indeed, and I hope you join us for future webinars. Today's webinar has been recorded, and my understanding is it'll be on the Centre for Palliative Care website within the next couple of days. So if it's not there, we'll please let us know if you want a copy, and we'll make sure you're alerted to the fact of when it is available. That's my understanding. It should be made available in the next couple of days. So thank you, everybody. Enjoy the rest of your day, and we hope to see you again for another Centre for Palliative Care hot topic in the future. All the best.
Thank you.
Peter.
Thanks, Peter.